Turn it on. Okay. Good afternoon. Today is March 25. The time is a few minutes past 4:30. The Insurance Committee of the Tennessee House of Representatives of the 114th General Assembly is now in session. Madam Clerk, please open the roll, and members kindly remember to log in. Okay, we have a quorum. Is it Mr. Clerk or Madam Clerk? Mr. Mr. Clerk, please announce the roll.
Mr. Chairman, you have 16 members present. You have a quorum.
Thank you. Members, thank you for coming for this late afternoon extravaganza. Do we have any personal orders? Seeing none, we will proceed with our calendar. Item 1, we have House Bill 0018 by Chairman Baum. We have a motion and a second. Chairman Baum, you're recognized on House Bill 0018. I don't see any amendments to it.
No, there are none. Thank you, Chairman Kumar. Since 2010, over the last 15 years, the state of Tennessee has had about 20 hospitals that have closed. These have all been rural hospitals, and they've all closed due to financial reasons. One of the factors that has contributed to these financial pressures has been uncompensated care. Patients who have received medical care at these hospitals but have not had insurance and have not been able to pay. This is a bill that is designed to help rural hospitals, really help all hospitals, by increasing the number of patients that have insurance and therefore compensation for care. This will remove some financial pressure on hospitals. And it does this, or it would do this, by expanding or extending the population that we have in Tennessee that would be eligible for TennCare benefits. Currently, we have a certain population that's eligible for TennCare benefits. This would expand that up to 138% of the poverty level, but it would do so on a temporary basis. And by that, I mean the individuals who would be part of this extended or expanded population would only be eligible for the benefits for a limited period of time. There'd be 2 time limits. The first one would be for no more than 1 year at a time, no more than 12 months in a 24-month period. And number 2, no more than 5 years in a lifetime. You may wonder where I got these time limits. They came from the 1996 Welfare Reform Act, where we switched from AFDC to TANF. Effectively, this would mean that the program wouldn't be an entitlement, wouldn't persist indefinitely. It would just be temporary assistance. Any type of expansion like this that has occurred has been funded with a $9 from the federal government match per $1 spent by the state. Federal government pays 90%, the state pays 10%. 40 states and the District of Columbia have expanded, but this would be a novel approach in that it would be the first expansion that would provide only temporary benefits for the expanded population, so that it would provide them with assistance when they really need it, but not something that they would remain on for the rest of their life. We passed a block grant program several years ago in this General Assembly. I would view this bill as complementary to the block grant program. In the block grant program, you may remember that if we spend less on our TennCare patients than the maximum permitted by the federal government, we get a share of that savings. And if we have a larger TennCare population, then we would get back savings on a larger base of people. I would want to fold this in with the block grant program so that we would receive these savings on the existing TennCare recipients and on the ones receiving these additional temporary benefits. This is something that would be designed to help rural hospitals, but it would also help our Tennesseans. We're paying for these benefits with our federal tax dollars. We're just not drawing them down. By that, I mean the 9-to-1 federal match per dollar in state spending. And a program like this that offers temporary assistance would be ideal for individuals who have been impacted by a natural disaster. And I'm thinking specifically of our East Tennessee constituents that were impacted by Hurricane Helene. The flooding resulted in loss of homes, loss of jobs, and with that, for many of them, I'm sure, loss of health insurance. And with these temporary benefits, they would have been able to move on a temporary assistance program like this, receiving benefits for up to a year period of time. I am happy to answer questions about this bill. I have spoken with a number of members on this committee, and I know that members are interested, and yet they have some concerns. And if those are concerns that need more time to study, then I would be happy to move this to some kind of a summer study program. But I'm happy to answer questions now if you have them.
Members, Chairman Baum is very gracious and understands the need as well as the points against this bill. Do we have any questions? I want to take a moment to clarify one matter about hospital closures. The causes of the hospital closures are not poor payer mix or too much charity care alone. The charity care that the hospitals give is compensated by the federal government actually the money is distributed through TennCare. And the hospitals, depending on the category, can receive anywhere between 52 to 70% of their cost. So it's not that the hospitals are totally exposed and charity care is not compensated at all. And secondly, the other cause is, again, reorganization and corporate considerations about closing certain facilities if there is another facility available. If there is a county or an area where there is not a nearby hospital, again, the federal government does have a program called critical access hospitals. When a hospital is more than 5 miles with no other facility, that hospital is not closed, and federal grants will work to maintain and keep that place open. So those are two things that are available in our safety net to provide care for our patients, so that they are, because of hospital closures, there is not undue suffering to the people. Thank you for letting me explain that. And otherwise, members, you have questions. Chairman Spicky, you're recognized.
Thank you, Mr. Chairman. I think one of the interesting concepts you brought up here is trying to help people in need that have maybe had a natural disaster. Being a member of the insurance committee the last 7 years up here, the one thing I found is over the last 4 years, through reversion, TennCare has reverted almost $2 billion back to the general funds. And one of my colleagues is no longer on this committee, or I don't see him. I know he's not on this committee anymore. We tasked last year FNA about this whole issue of, well, why aren't we holding that money in TennCare that the General Assembly has allocated to help people instead of reverting it back to the general fund to just be absorbed into the budget? We talked about a year or so ago when we all got noticed that our budget was about $700 million short. And then we had the reversion from TennCare of about $705 million, and mysteriously, all of a sudden, our budget woes were over. If we could have had that $2 billion in a grant fund administered by TennCare to look at programs that we could do to help more people that we're in control of without relying on the federal government, it might give us the latitude to help people and create grant programs administered by the TennCare people that are doing a fantastic job that we're going to hear of shortly here, through the shared savings plan that one of my colleagues sitting here helped write. And I want to say I'm very gracious of Chairman Baum to give the option to look at this longer instead of having a definitive vote right now. And so with that, Mr. Chairman, I'll make a motion that we send this to summer study so we can take more time to get more interest in this.
Second.
Would you be kind enough to allow a couple of our members to make some remarks and hold your motion? So we could circle back to you.
Mr. Chairman, if the member who seconded it would withdraw theirs temporarily, I'll withdraw mine temporarily.
Is everybody in a good mood? Okay. Thank you. Representative Hakeem, you're recognized.
Thank you, Mr. Chairman, and Representative Baum, thank you for presenting this bill. And I didn't hear you say anything about summer study, okay? I think it's worthy enough to be considered now. And my reason for saying that, we know the need is there and it's not being met. And I would hope that we would take that under consideration as we look at this bill. And I would hope that it moves forward. When you talk about a 9-to-1 match, I don't know how much better it can be. And I would hope that we take all of that into consideration, in particular, as we said, the need, if we look at East Tennessee, in particular, Upper East Tennessee, and throughout the state. Thank you, Mr. Chairman.
Thank you for your brief remarks, and let's keep it brief, members. And of course, we are fortunate to have TennCare to testify today, and we will, a lot of those questions will be addressed. Yes, Chairman Baum.
I was just going to respond to the 9-to-1 match and some of the other comments we've heard. In budget hearings last year, TennCare had in its reserve account, last I remember, over $1 billion. And in fact, that account got so large at one point a couple of years ago, members may remember, we set up a TennCare task force to identify ways to spend that money. One of the ways we came up with was to spend money on diapers. You may remember that we did that last year. Here's one of the advantages that this bill offers. With this waiver that this bill would authorize, it would get a 9-to-1 federal match per state dollar. As far as I know, the money we spend on diapers don't generate any kind of federal match. So with over $1 billion in reserve, in the TennCare reserve, that's not our general fund rainy day account. That's a different account. That's TennCare's reserve account. We spent some money on diapers, doesn't get the match. We've got money on hand. This kind of expansion would get the match.
Well, thank you. Chairman Hill, you recognize, sir.
Thank you, Mr. Chairman. And this is a question, and Chairman, we may not be able to answer this, and I also have a statement that I'd like to make about the legislation. But when we're talking about a summer study, what are we talking about? Is this an old school summer study where we don't hear about it ever again? Or is it an intent to call the committee back together and look through the legislation? And Chairman, could you speak to that, or is that a off-topic question?
No, it's a very incisive question, and that it actually remains to be seen. And usually that depends on the initiative that the sponsor will take.
Okay, thank you, Mr. Thank you, Mr. Chairman. As the sponsor of the block grant bill, and that's not something that I try not to bring it up because it's been tremendous success, and that's not something that I can lay claim to. Certainly not solely. The Bureau of TennCare has been amazing, and there's a whole different discussion associated with the reserves. But I would respectfully, and I appreciate the intent of the sponsor to creatively expand Medicaid, but this is the antithesis of the block grant legislation. It is not a complement. It is the antithesis of what we set out to do years ago, because this body historically has been against Medicaid expansion for a host of reasons. And as those various votes have taken place, the reason we brought the block grant forward was because we were trying to serve more people with existing resources. And with the and this is the antithesis of the block grant. This is the reason we brought the block grant forward, is because this is something that is detrimental overall to the financial and fiscal health of TennCare and of the state. And so I don't want there to be any misunderstanding. I'm not convinced I can vote for a study motion, and I certainly can't vote for this legislation as it sits. Thank you, Mr. Chairman.
Thank you, Chairman Hill. Members, those of us who may not remember, Chairman Hill was the sponsor of the block grant legislation, and we are grateful to him for that. Last on my list is Representative Parkinson. Do you know how to be brief, sir?
No, sir, I don't. I don't. I kind of I almost wanted to ask to roll this bill till after we heard from TennCare, and I love the fact that my colleague who we've been serving together for a very long time. I will not call his name so he can speak again, but this is the old school debate that used to happen back when he was first here. I've been here 15 years and I'm yet to hear why all of these reasons why we don't want to expand Medicaid. I haven't heard them yet, right? None of the reasons. Maybe they're being discussed somewhere else outside of my purview, but I'm yet to understand or hear why we would not expand Medicaid. Everybody up here on this dais got insurance that's provided by the government. Yeah, look at them, every one of them. But yet we do not want to give everyday Tennesseans an opportunity to have insurance. Yeah, it got real quiet in here. And this bill is so limited in scope, that I almost don't like it, right? But I'll vote for anything to give, Tennesseans the ability to have better access than this safety net, because not one person up here would want to be tied to the safety net. No shade to our safety net people out there, but there's not one person up here on this dais that would want to have to depend on the safety net for their health care, because it's hard to get in sometimes. It's hard to, get through those phones sometimes. It's hard to get an appointment, right? And there's so many people that depend on the safety net, right? And this bill would give people an opportunity at having access to healthcare, or more people having access to healthcare. And this is sad and unfortunate, but I did want to ask the sponsor, did you talk to the governor about this idea at all, or his administration or staff, or should I not be asking that?
I have not talked to the governor.
Okay. So and with that, what this bill is doing is simply giving the governor an option. It doesn't mean he has to do it, right?
Chairman Baum?
The bill would require the governor and TennCare to negotiate with the Trump administration on terms that would include the 9-to-1 federal match for an additional population with time limits on the benefits.
Right. And so, and thank you, Mr. Chair. So, and if the negotiations were not favorable to the state, would he have to do it?
Chairman Baum?
The bill does specify the 9-to-1 match. And so if the Trump administration would not be willing to agree to that, then there would be no deal. That would be part of the waiver negotiation process.
And just the last thing. So, I'm looking at the fiscal note, and this would bring in an additional $2 billion with a B to the state of Tennessee. Am I getting it right or getting it wrong?
Chairman Baum?
I think that's roughly right in the fiscal note.
Right. And TennCare was reverting how much money back to, or how much did they have in their fund? Was it $1 billion that I just heard from somebody?
Chairman Baum?
I was saying my recollection from last year's budget hearings was that the TennCare Reserve Fund was, I think I remember it being at $1.1 billion, but they'll be able to tell you that information specifically.
Yeah, because we're going to ask that 1.1 billion to the point that TennCare is in the lending business now. But thank you for your attempt. I hope that it'll actually be a study and not a death. If that's what you're going to do, if that's your will. But I just, for the life of me, I'm still not understanding what our apprehension is to giving other Tennesseans an opportunity to have insurance. But thank you, sir.
Thank you, Representative Parkinson. I think you know also that at this time, our TennCare budget is about 1/3 of our total budget. So this is a body with a heart, and we are doing what we can. Is it ever enough? And that we will find out. Thank you very much. Thank you, Chairman Baum. Coming back to Chairman Spickey, kindly renew your motion.
Move previous question. Vote it down. Vote it up or down. Nope. They want to vote on it.
We
Vote
have
up or
a
down.
motion. Do we have a second?
Second? Oh, I made a motion. Sorry, I can't do that.
Do we have a second? We have a second. We have a motion and a second. Are we ready to vote? Without objection, we are voting on. Yes, Representative Parkinson?
Thank you, Mr. Chair. Mr. Chair, the question was called and I seconded. That was the only motion on the table, the calling of the question. There was no motion for a summer study or anything. He called the question. I seconded. We should be voting unless the parliamentarian says otherwise.
Representative Parkinson, we are voting on the bill.
Oh, okay, thanks. Okay.
Okay. Are we ready to vote? Without objection, Mr. Clerk, kindly open the vote. All those in favor, please say yes. All those opposed, say no. Has everyone voted? Does anybody want to change their vote? Mr. Clerk, please count the vote.
Mr. Chairman, you have 4 ayes, 14 nays.
Thank you. The bill does not receive the required majority and therefore fails. We'll go on to item 2, which is also by Chairman Baum. House Bill 0494. Chairman Baum, you have a motion and a second. And on that bill, we do have an amendment.
Yes, it is Amendment 3693.
Right. So we have a motion and a second to attach Amendment 3693 to House Bill 0494. All those in favor, please say aye. Opposed? The amendment goes on the bill. Chairman Baum, kindly explain to us the amended House Bill 494.
Thank you, Chairman Kumar. Members, you're going to like this bill a lot better. This is a bill that would allow independent contractors to receive employment benefits through a portable employment benefits account without changing their employment status for tax purposes. When I refer to independent contractors, here's who I have in mind. Gig workers, freelancers, consultants, individuals who have temporary employment, individuals who have multiple jobs. I think of folks like DoorDash workers or Uber drivers, Lyft workers. These are the independent contractors we have in mind. Contributions to their portable employment benefits account would come from the customers who hire them. It could come from contributions from the independent contractor themselves. It could come from multiple employers. It could come from relatives or family members. These contributions would go into an account. The account could be used to fund different kinds of common benefits. These could include health insurance benefits, income replacement insurance, life insurance, retirement benefits. And the accounts would be managed or administered by a third-party provider. This bill would attempt to do that without changing the employment status of the independent contractors. And the characteristics that would need to be present would be, number one, the portable benefit accounts would need to be voluntary. No independent contractor would have to have one, but they could have one if they wanted. The account would need to be flexible so that the independent contractor could select whatever benefits they want. It might be that they have a spouse who provides health insurance benefits, and so they would want the contributions to be used for retirement benefits. And the accounts would need to be portable, tied to the independent contractor or the worker, so that they could stay with the worker through multiple employers, or if the independent contractor changed jobs. Without this legislation, our independent contractors are in a position where they either have to go without many of these benefits, or if they receive the benefits, they lose their tax status. Their tax status changes from essentially being a 1099 type worker to being a W-2 type worker. This bill allows them to receive employment benefits without losing that employment status, or that employment status changing.
Thank you. Members, do we have any questions? You've heard the explanation. Questions been called without objection. We are voting on House Bill 494. Mr. Clerk, please open the vote. All those in favor, please say yes. Opposed, no. Has every member voted? Almost, okay. Mr. Clerk, please count the vote.
Mr. Chairman, you have 18 ayes, 0 nays.
Thank you. The ayes prevail, and the bill moves on to calendar and rules. Congratulations.
Thank you all.
Thank you. Item 3 is House Bill 0029. At the request of the sponsor, this is rolled 1 week. Item number 4, House Bill 1242 by Chair Lady Helton Haynes. We have a motion and a second. Madam Chair Lady, you're recognized on House Bill 1242. I see an amendment 4543.
That's correct. Thank you, Mr.
Okay.
Chairman.
I have a motion and a second on amendment 4543. 4543. Going on to House Bill 1242. All those in favor, please say aye.
Aye.
Opposed? The amendment goes on the bill. Kindly explain the amended bill to us.
Thank you, Mr. Chairman. In 1992, Congress, with bipartisan support, enacted the 340B drug discount program. It allows eligible healthcare providers, called covered entities, to purchase outpatient drugs at discounted rates to stretch federal resources, increase access, and provide comprehensive care to the most vulnerable patients, the low-income, underinsured, and uninsured. The amendment is just clarifying in nature. This bill only applies to pharmaceutical drug manufacturers, and the language we are striking in Section E ensures that. We have also included in the amendment language to ensure that savings from the 340B program will be utilized in a manner that adheres to all applicable federal and state laws regarding immigration, citizen status, abortion, and transgender care for minors. House Bill 1242, as amended, would protect access to affordable health care for Tennessee's most vulnerable patients and the safety net providers that serve them. The bill does two main things. First, it ensures that drug manufacturers cannot interfere with or restrict safety net providers' contract pharmacy arrangements, including limiting access to these pharmacies, which are lifelines for patients in rural and underserved areas of the state. Second, the bill protects 340B covered entities from excessive data requests from drug manufacturers as a condition for 340B drug access. Manufacturers would be precluded from trying to shift the program from an upfront discount to a post-sales rebate model, which would create unbearable financial burdens on our safety net providers. Thank you, Mr. Chairman, and with that, I stand for questions.
Thank you, Madam Chair Lady. Members, I assume you have questions, but we also have testimony. let us hear the testimony before and then take up the questions. We will go out of session. We have 3 people who have signed up to testify. First is Ms. Sarah Bellog. Ms. Bellog, welcome. You know the spot. Your mic is on. Kindly give us your name and identify who you are with.
Okay, good afternoon or good evening almost. My name is Sarah Baylog. I'm a Senior Director of State Policy with Pharma. So thank you so much for the opportunity to present today. I'm sorry, sir?
You have 3 minutes.
Okay, 3 minutes, perfect. As the chairwoman noted, Congress created the program in 1992 with bipartisan support and with the support of our industry as well. We are concerned that the program has gone off the tracks with a lack of transparency and a lack of oversight, which has led to abuse of the program. Through this program, biopharmaceutical manufacturers provided $66.3 billion in medicines at significantly reduced prices in 2023 to qualifying safety net hospitals and certain clinics, but patients are often not benefiting. Today, large tax-exempt hospital systems, chain pharmacies, and PBMs are exploiting the 340B program by marking up medicines for profit, even though its intended beneficiaries were true safety net hospitals and clinics and the low-income and vulnerable populations that they treat. The 340B program has strayed far from its safety net purpose, and Congress needs to fix the program to ensure that it is reaching its intended populations. Additionally, the 340B program has become a hidden tax on employers and their workers. Marking up the cost of 340B medicines for employer-sponsored commercial plans and patients with private insurance generates significant revenue for 340B hospitals. The current design of the program directly increases costs for employers by an estimated 4.2% or $5.2 billion due to foregone rebates from manufacturers, which reduce the price of medicine, and indirectly increases employer costs by incentivizing provider consolidation and the use of higher cost medicines. Employers in Tennessee pay an estimated $124 million more in healthcare costs due to foregone rebates as a result of the 340B program. The 340B program has fiscal implications for state employees and ultimately taxpayers. Contract pharmacy mandates like HB 1242 increase their costs. We see this in the fiscal note on the bill that estimates that a state 340B contract pharmacy mandate would result in an estimated $7 million per year in additional costs to the Tennessee State Health Plan. The 340B program is governed exclusively by federal law and needs comprehensive reform at the federal level to help at-risk communities. Pharma respectfully opposes HB 1242 and appreciates your consideration prior to advancing the bill. And I'm happy to answer any questions.
Thank you, Ms. Bellog. Members, do we have any questions for Ms. Bellog? Representative Hakeem, you're recognized.
Thank you, Mr. Chairman, and thank you, ma'am, for being here. Could I ask I'm going to call them guardrails that Representative Helton Haynes spoke of? Would that put from your perspective, the program back in the intent mode that was sought and gotten early on? Or do you feel that it doesn't meet that test?
Well, one of our largest concerns with the bill is the section, the latter half of the bill that essentially prevents manufacturers from seeking any data about how contract pharmacies are, identifying patients, whether double discounts are being taken, who the patients are, where they live, whether they're actually low income. It's already a relatively opaque program. And with bills like this, with language that essentially prevent transparency into the program, it makes that problem worse, not better.
Representative Hakeem.
Thank you, Mr. Chairman. The original bill and intent, did it or did it not provide the type of transparency that you're speaking of? And you feel that it's not there now?
Right, and we're working, at the federal level to bring some of the needed reform and some of those insights to the original statute. I think the important thing to know about the 1992 bill is it's 8 or 9 pages long. That's not a very robust piece of federal legislation, and that lack of specificity has kind of led to the expansion that we've seen in 2010, and essentially the sub-regulatory guidance from HRSA at the federal level that is saying that they can pursue unlimited contracts with pharmacies, and that's not in the statute. And so that's really the point of contention that we're seeing play out with these bills.
One last, if I may.
You're recognized.
Okay. I think I heard you say that they are taking actions now that were not in the original statute. And so I guess earlier I asked about if the guardrails, if they were sufficient to, stay within the guidelines, and maybe I'm not interpreting correctly.
Sure. So the original statute doesn't speak to contract pharmacy at all. It was envisioned essentially to be in-house pharmacy. So a hospital, an FQHC, a Ryan White clinic that had a pharmacy on site. It was in 2010. The concept of having a contract pharmacy, which was having one contract pharmacy, was introduced by HRSA in 1996. And then in 2010, essentially HRSA, without going through Congress, said that contract pharmacy can be unlimited. But again, that's not what the law says. So that's why, unlimited contract pharmacy is not something that's envisioned in the federal statute.
Thank you, Mr. Chairman.
I hope you were not surprised by the confusion in federal law.
Of course.
Seeing no other questions, thank you, Ms. Bellard.
Thank you.
Okay. The next speaker we have is Mr. Steve Pate. Call the other one also. Also, Dr. Shannon Berger. Thank you for coming. When there's a red light, the mic is on. Kindly identify yourself and who you are with.
Thank you, Chairman Kumar.
Each of you have 3 minutes.
Wonderful. Thank you for allowing us to testify today. I'm Dr. Shannon Berger, CEO at SIMPA Community Care. We are a federally qualified health center based in Chattanooga, Tennessee, and I also serve on the board of directors for the Primary Care Association.
Steve Pate. I'm a Deputy Chief Pharmacy Officer at St. Jude, Senior Director. Been with St. Jude for about 20 years. As you know, St. Jude provides care for patients all over the world. We treat catastrophic childhood diseases that many other places don't. And this is one of the programs that's vitally important to what we do every day.
So for more than 30 years, the drug pricing program has provided vital support to eligible safety net providers who serve Tennessee's most vulnerable populations. This includes children battling cancer and individuals living with chronic diseases. The 340B program was established to stretch those scarce federal resources, reaching more eligible patients and providing more comprehensive services, all without adding further burden to taxpayers. The reason this legislation is so important to safety net providers is because in recent years, pharmaceutical manufacturers have begun imposing unilateral restrictions that hinder the provider's access to these discounts. The limitations restricts choices for independent pharmacists and safety net providers, diverting funds away from Tennesseans without benefiting those in our state, but ultimately enriching shareholders. They are limiting the use of contract pharmacies, which are vital for patients in rural and underserved areas, and they're attempting to shift the program from offering upfront discounts to a post-sale rebate model, which would create significant financial burdens for our providers. I want to address the misinformation that has been circulating about this issue. You may have heard things like, this program has spiraled out of control. In fact, the growth of the program directly correlates with the exorbitant rise in drug prices. I would challenge pharmaceutical manufacturers to take responsibility by cutting back on their enormous spending on marketing and lobbying and instead lower drug prices. To put it plainly, prices in the United States are 3 times that of other developed countries. Yes, our prices are an astoundingly 278% higher than what we see abroad. You may also hear things like, there is a markup. There is no markup. As a condition for manufacturers to have their pharmaceuticals covered under Medicaid and Medicare program, they are required to sell outpatient drugs to eligible safety net providers serving low-income and rural populations. You also may hear things like, there isn't transparency. However, covered entities participating in this program in Tennessee are not for profits. They are subject to audits by HRSA, drug manufacturers, state comptrollers, and through public records of their own financials. In contrast, pharmaceutical manufacturers profit significantly, making billions. So the real issue here is that Big Pharma is attempting to increase their profits at the expense of our community health centers, rural hospitals, and other safety net hospitals. Other states have taken notice. I'm pleased to share an updated map of which states have enacted similar legislation if anyone would wish to review it. But notably, the Fifth Circuit Court of Appeals has upheld the Arkansas law, while both district and federal courts have upheld the Louisiana law concerning 340B contract pharmacy. These laws restrict pharmaceutical companies from interfering with contract pharmacy arrangement, just like the measures proposed to you in front of you in House Bill 1242. We are the rural healthcare providers, the safety net clinics, local and county public health departments, small community hospitals, and we don't have the same negotiating power as large pharmaceutical manufacturers.
Dr.
Please.
Berger,
Yes,
sorry.
That's okay.
Your time is
Okay,
over.
perfect.
If you want to wrap up with a sentence, you're welcome to.
perfect.
Or Mr. Pate,
Yes. Thank you, Chairman.
you have
Members of
3
committee.
minutes.
Came to you today as a participant in the 340B program. As many of you know, St. Jude treats patients with catastrophic diseases, and it's a very costly venture. But what's central to our mission at St. Jude is that patients never pay. They never pay a penny for any of the care that they're provided. And one of the things that's inherently great from a provider's perspective like ours, with this being an outpatient program, is we deliver a fairly large amount of care in an outpatient setting. So patients don't have to be admitted and they don't have to spend more time at St. Jude than they need to. And because of the amount of care that we provide in the outpatient setting, we are able to benefit from the 340B program. And the benefit that we see from the 340B program helps offset many of the exorbitant costs that we're already seeing from a pharmaceutical perspective and then other segments of the care continuum. So this program is at the heart of what we do from a mission perspective. And I can't hammer that home any plainer. I mean, it really is vital to what we do on a daily basis to be able to have the funds that are generated through the discounts and then being able to apply those to other segments of care within the institution and help support things that we do to expand care so that we can provide more care to patients as they come in. Thank you.
Well, thank you. Members, we have questions. Chairman Spicky, you're recognized.
Thank you, Mr. Chairman. I'm very curious about what you were going to say next, so can you finish?
Oh, sure. I was just going to ask that you all support this legislation because it does impact the safety net providers in Tennessee. I was right at the end.
Thank you, Mr.
Thank
Chairman.
you.
Thank you, Mr. Chairman.
That was a benevolent thing to do.
Thank you.
Members, do we have any more questions for our witnesses? Representative Hakeem, you're recognized.
Thank you,
I was
Mr.
gonna
Chair.
call Spark first, 'cause
Um,
Hakeem's had his time.
Dr. Berger, where you spoke of, I think Farmer is sort of changed the system, dealing with so that more funds, I would say, go into, I guess, stock returns and so forth. The actions that they proposedly taking now, is that different from the original intent or the original understanding?
Yes, sir. As a matter of fact, I testified in front of the subcommittee last week, and between that time and today, we had 2 more alerts of more contract pharmacy restrictions that were being imposed across all covered entities. And so it is not the original intent of the program at all.
Thank you, Mr. Chairman.
Chairman Sparks, you're recognized.
Yep. Thank you for your testimony. My understanding of the program has increased from about 9 billion when it first was in 2014 to about 38 billion. How come the cost has increased so much?
Some of that is due to drug pricing increasing over time. That's a lot of it. And then in 2010, when the ACA was expanded, it did afford eligibility to a lot of hospital systems that provide an abundance of charity care. And so I would say that attributed to the growth.
Yeah, I would agree with the drug cost perspective as well. I mean, just at St. Jude in the last 5 years, we've seen our drug costs increase 40%. And some could say it's the catastrophic kinds of drugs that we use on a regular basis to treat those patients. But it's not just those high cost innovator type of medications. It's medications across the board. And we're continuing to see that cost from a medication perspective grow. We're forecasting that it's going to continue to grow into the future. And so this program is one of the reasons this is vitally important is because it helps mitigate some of those pricing challenges, cost challenges that we're seeing in the market.
Chairman, my understanding is DOGE, Department of Government Efficiency, is looking at this. Is this true? I mean, are they starting to investigate some of the 340B program? Have you heard?
I'm not aware of that.
We are not aware of that.
Yeah.
And I've not been aware of that at the national level either. I serve on a national board.
Should it be looked at?
I think that any program is subject to being looked at, and we can improve upon anything that we do. But we are very diligent about what we've brought before Tennessee to ensure that it benefits our patients and saves the state money.
I loved a speech I seen last night. I really liked the speech last night. But when our drug costs are so much more than other countries, why is that? Because we're, like I said last week about the PBMs, settle down over there now, settle down. And, but when I see the drug cost, it worries me. We've got members up here that's had family members battling cancer. Drug costs are high. I had a sister in nursing home for 6 years. She passed last year. Seen her lose everything to her name. But, it just seems like we're the capital of the free market. And this is so convoluted. Why is it so convoluted?
Chairman Sparks, that's a much larger subject.
But I mean,
and there is,
with all due respect, Chairman.
There's something called the federal government involved.
Yes.
And really, I think to wrap it up, we have other presentations coming. I think that there may be a hope in the fact that the federal government is now asking or allowing Medicare to negotiate drug prices in a small scale over the last couple of years. As that grows, I think that will be a useful program. At this time, those negotiations are limited to those. But we are not going to solve drug problems.
I know we're not.
Problems.
But here's
Kindly wrap it up.
Well, I'll just say, here's what bothers me with government. Okay. We're going to have a 15-minute conversation about something that's so serious that everyone should be concerned about, and we should fix this stuff and be aggressive about it, because something's messed up with this stuff. It's complicated. I think they keep it complicated on purpose. I've got the 2 largest drug distribution centers in my district, McKesson and Cardinal Health, and I'm proud of the jobs they provide. But it's convoluted. I wrote a column a couple of years ago, and I said there's no better term for healthcare than cattywampus, and I included Dr. Van Horn at Owen School of Management at Vanderbilt. But I just think, Chairman, we should dig down on this kind of stuff and not just barely go over the surface of this stuff and be aggressive on this. That's my
Thank you,
sermon for the
Chairman
day.
Sparks.
Thank you.
You can invite us all to dinner and we'll talk about it at length. Any other questions for our witnesses. Thank you for coming. We really appreciate you've had to travel, but I think it's meaningful for us to make some decisions. Thank you.
Thank you.
We'll go back into session. Members, do we have any questions for our sponsor? Seeing none, Madam Chairlady, do you have any closing remarks?
Yes, members, our safety net providers are the good guys, and I humbly ask for your support. Thank you.
Seeing no other questions, without objection, we are ready to vote on House Bill 1242. Mr. Clerk, open the vote. It's Madam Clerk. Okay. All those in favor, please vote yes. Opposed, no. Has every member voted? Does any member want to change their vote? Madam Clerk, please take the vote. Or Mr. Clerk.
Mr. Chairman, you have 16 ayes, 1 nay, 1 present not voting.
The House Bill 1242 moves on to Finance, Ways and Means. Thank you.
Thank you, Mr. Chairman and committee.
Members, do we have any other business for the committee? We will move on to TennCare presentation. And we will go out of session. Mr. Commissioner and team, thank you for coming. Thank you for your patience. Kindly, we're going to get your mic turned on and kindly identify and tell us who you're with.
All right. Thank you very much, Mr. Chairman and members. It's a privilege to be with you all this afternoon. My name is Stephen Smith. I serve as the director of TennCare. We have a full crew here today. To my right is Zane Seals, our chief financial officer. To my left, we have Katie Evans, our chief of long-term services and supports. Dr. Victor Wu is our chief medical officer, and Kim Hagan is our director of member services. Mr. Chairman, we've been invited here today to provide a general introduction and update on the TennCare program, and we very much appreciate that opportunity. As some of you all know, last year, TennCare and the state of Tennessee, we had a milestone. It was TennCare's 30th anniversary, and our state has a long and complex history when it comes to Medicaid. It's one that is filled with both challenges and achievements as we have strived to meet our mission of improving lives through high quality, cost-effective care. But I'm very pleased to be able to say to you today that when it comes to that mission, we are more successful than we have ever been in our 30-year existence. And that's not due to any one person or group or period of time, but it's many people working together over several years, building upon the work of the people that came before them. So that's multiple governors and leaders, legislators, committees like this one that have taken us to a place where the TennCare budget was literally going to take every available new state revenue dollar to one where we have record improvements in TennCare, while at the same time having record improvements in public education and other priorities within state government. And that is not a coincidence. It's why we take so seriously this idea that TennCare is about much more than just Medicaid. I know many of you are already familiar and have a good amount of knowledge about TennCare, but I thought it might be beneficial to level set here and quickly go over some of the basics of our program before we get into just more detail. So TennCare is a traditional Medicaid program in terms of our categorical coverage, meaning that we provide health insurance for primarily low-income children, pregnant women, parents, elderly, and individuals with disabilities. And there are income and resource tests and requirements that differ based on those particular categories. Today, we cover approximately 1.4 million people. That's about 20% of the state's population. We cover about half of the births that occur in this state each year. You all know very well it takes a tremendous amount of money and resources to run a Medicaid program. Today, our budget exceeds $18 billion. That's an incredible amount of money. It represents almost a third of the total state budget. It's about 23% if you look at just state dollars only. That cost figure is, of course, extremely consequential to the state. I have yet to meet anyone that disagrees with the statement that healthcare costs have risen and are rising at unsustainable levels. There are a lot of opinions, and there is considerable discussion that is taking place right now, certainly at the federal level, about why that is and what should be done about it. But we as a state, we have a role to play in that discussion. Of course, Medicaid is a federal and state partnership. We receive about 65% of our funding from the federal government. Regardless of that split, however, all of this represents taxpayer dollars. And we have a responsibility to keep our cost trends to a reasonable level, while at the same time maintaining and improving quality of care. Now, we're not naive enough to think that one Medicaid program in the Southeast can solve our healthcare cost challenges, but we should at least try to do our part. And that's what we have done. And a primary way that we have done that is through managed care. So TennCare, Tennessee is a managed care Medicaid program, meaning that we contract with health plans to coordinate care for our members and create and maintain a network of providers, which includes negotiating payment rates and contracting with those providers. That coordination of care piece is instrumental to our work. The goal is to provide the right care at the right time in the right setting at the right cost. Managed care, though, is so much more than simply negotiating and contracting and payments. Tennessee was a leader in managed care many years ago, and other states have followed our lead. In fact, today, nearly 3/4 of all Medicaid members in the country are served through managed care. I mentioned earlier how far TennCare has come as a program from those early years and even in the last few. This slide illustrates the program's evolution. It's one that was unpredictable and unsustainable with limited services to one that is managed, well managed, and highly valued. Effective management is not an option for us. It's a must. If we do not manage the program well, we only need to look at our own history to understand that there won't be any resources left to meet all of the other needs of state government and those that our citizens expect and demand. This reality is illustrated in this slide. What you see here is a trajectory in the early 2000s that I mentioned earlier, where TennCare was set to engulf every new available state revenue dollar in just a few short years. That, of course, was not an option. And so our state took the first steps then to right the ship and put us on a path that led us to the enviable position where we are today. The actual numbers here are staggering, and frankly, they are hard to believe. But without these reforms, we would have spent a cumulative $70 billion in additional state funds, and our budget today would be $6 billion more than it is. Now, you may say to yourself, that's ridiculous. There's no way that would ever happen. And I think that's the point. That's an astronomical amount of money that would be unacceptable, meaning the record investments that we've seen for benefits and services and people and providers, those that we've seen over the last 5 years, they just simply don't exist. And often lost in the discussion is the fact that the other investments that are so important to our state, including the record investments for public education and infrastructure, they never materialize because the dollars are spent before we can consider anything new. It's again why we stress our mission of improving lives is not just about improving the lives of the TennCare members that we serve, but the lives of all Tennesseans. We've met that mission through effective managed care, but also focusing on things like home and community-based services and value-based payments, where we can pay based on quality versus simply quantity. On the subject of quality, while we have made tremendous progress when it comes to fiscal stability, we've also made great strides in quality. That's demonstrated by our performance on common and recognized national metrics. In fact, over the last 5 years, we have exceeded the national average in 56% of the metrics. Now, we are not satisfied with 56%, but you compare that to the previous 5 years when we hovered around the low 40s, and that does represent marked improvement. And an important point I want to stress here is it's not a coincidence that these quality improvements have coincided with improvements in the cost effectiveness. And I bring that up because sometimes people will say that the cost effective piece of our mission comes at the expense of quality of care. And it's actually the opposite. They are dependent upon one another. It's cost effectiveness that leads to available funding to improve quality, and it's improved quality and health outcomes that lead to decreased costs. We've proven this with real and tangible evidence over the last 4 years with our latest innovation known as TennCare 3. As a reminder, and you all have already talked about this some today, TennCare 3 was implemented in January of 21. It was a first of its kind waiver agreement entered into by the Trump administration and the state of Tennessee. And the impetus of this, of course, was a directive by the General Assembly. You mentioned Chairman Hill's sponsorship of that bill, but it was back in 2019. And it was a great example of collaboration between the executive and the legislative branches. And at its core, the concept of TennCare 3 was to try to move away from a flawed financing model whereby the only way that a state Medicaid program could receive more funding is to spend more, and instead reward Tennessee for its successful and responsible management of its Medicaid program through additional federal funding that we call shared savings. Since the inception of this waiver, we have had the largest TennCare investments than at any point in Tennessee history, highlighted first by the addition of a comprehensive adult dental program. That's 600,000 adults whose lives will be positively impacted through dental care. In addition, we've had the goal of eliminating the waiting list for individuals with intellectual and developmental disabilities that are seeking services in our ECF Choices program. We received significant funding to attack that goal a couple of years ago. Thank you all for that. And today we're serving 2,300 more people. These record investments extend to our provider community as well, with billions of dollars in new provider investments, in addition to the negotiated rate increases through managed care. And I want to pause here and just recognize our exceptional provider partners. When we talk about TennCare success, we are reflecting the success of our providers. They continue to work and excel in a very challenging environment, and we owe them our gratitude. But all of these investments that I mentioned are possible because of the confidence that we have to be successful under the provisions of TennCare 3. And now we have confirmation, not just 1 year or 2 years, but now 3 years, that not only is TennCare 3 working, it is an unparalleled success. In just the first 3 years of this 10-year waiver, we have achieved nearly $1 billion in shared savings that we can then reinvest to benefit the lives of the people that we serve. And that is exactly what we are doing in partnership with the General Assembly. In year one, we focused on the Strong Families Initiative. And today we're serving 25,000 additional children and pregnant women and parents. For year two, we focused on 2 areas, rural health and behavioral health. And now we arrive at year 3 with another large shared savings claim. In fact, it's a record amount. And as you may have seen in the budget, we are focusing on long-term care and services, but we are very proud to be able to utilize a portion of the year 3 savings to partner with TEMA months ago to provide immediate assistance and help to the communities and Tennesseans impacted by the hurricane. But at the end of the day, TennCare 3 and the shared savings efforts, they are about improving health, which drives down healthcare costs, which results in shared savings, which results in a reinvestment of those savings to improve health. And so it's a cycle. Before I wrap up, we were asked to cover our eligibility redetermination outcomes. And as you know, this was such an important part of our work over the last couple of years. As a reminder, from April of 23 to March of 24, we, along with every Medicaid program in the country, undertook the enormous task of Medicaid unwinding from the 3-year pause in renewals brought about by the pandemic and the federal government. So that 3-year pause resulted in an increase of enrollment of about 26%, over 350,000 members. The results clearly show that Tennessee has been a model for effective planning and implementation of the unwinding process, including more communication and outreach to stakeholders and members than ever before. Not only did CMS at the federal level approve Tennessee's unwinding plan, but Tennessee was one of only a handful of states that did not have to pause renewals or submit a mitigation plan at any point during the unwinding process. And because of that, today we are back to pre-pandemic enrollment levels. And that translates into hundreds of millions of dollars in negative impacts to the state budgets. And you can see that playing out in some states across the country. So the fact that we were able to do this well, do it on time, it has really benefited us. In terms of enrollment, we exceeded the national average in terms of our renewal rates. We exceeded the national average in terms of our automatic renewals, meaning that certain members did not have to do anything to renew. We could use other available sources of information to do those automatic renewals. So we can be proud of our collective efforts around eligibility and renewals, and the fact that it really has never been easier to renew TennCare membership. And then I'll close here. I started the presentation by saying that TennCare has never been more successful than it is today. And I can think of no better proof of that success than what our own members say. Each year, some of you know this, the University of Tennessee conducts a survey of Tennesseans' satisfaction with their health insurance plans. And that's an effort to gauge their satisfaction with the TennCare program. This year, we are really happy to report that we have a record 96% satisfaction rate. And last year, for the first time in the survey's history, reported quality of care for TennCare households and their children met or exceeded reported quality of care for all Tennessee households. So that includes commercial and private insurance. So that's something that we can be very proud of. That is in no way to suggest that we can't and should not improve. We always have places where we can improve, but hopefully it shows that we're doing something right, or at least we're on the right track. I know that was very quick, Mr. Chairman. Out of respect for your time, I will stop there, and we're happy to answer any questions or hear any comments that you all have.
Thank you. That was very concise and meaningful. I noticed that the number of enrollees, traditionally, to my knowledge, it had been about 24 to 25%. At this time, it is close to 20%. Is that true?
That's right. We're about 20% of the population today.
And what has caused that decline?
Well, I think our strong economy has a lot to do with it. So when you look at the percentage, we've had some population growth, of course, in Tennessee, and we have a strong economy. And so I think those two things result in a lower percentage.
But that is good. It decreases the cost also. What is the poverty threshold for a person to qualify?
It depends on, of course, the size of the family, but and it depends on the category as well. But for example, for children, we cover children of up to about 250%. So 250% of poverty for a family of 4 would be $76,000. For a parent, the parent or caretaker relative, the threshold is 100% of poverty. So for a family of 4, that would be $31,200. But it's going to depend on the particular category and what the income threshold is for that category.
Well, thank you. It's of a bit of concern that despite improvements in our economy, 50% of our children are born dependent upon TennCare. Thank you. Chairman Grills, you're recognized, sir.
Thank you, Mr. Chairman. And Commissioner, just thanks for coming in at this late hour in the afternoon. Real quick, if you would just explain to me, are there different plans that a TennCare recipient can be on? And what is the financial responsibility of the policyholder at different levels?
Sure. So we have 3 health plans that we contract with, but they all provide the same benefits. So they're we require all of them to provide the same benefits, the same Medicaid benefits. The member does have choice, so we will assign the member upon enrollment to a particular MCO, but they do have choice after that to move from one MCO to another. And then what was the second part?
What is the responsibility on that policy holder?
Oh, the financial responsibility?
Do they have any? And is that a
Um,
graduated scale or moving scale?
There are some, though no premiums. There are some copays.
Okay, and let's focus on that then. What are the copays?
Yeah, I'm going to defer to Kim. I mean, it's going to depend on the particular category, but do you want to
Sure.
speak to that?
Sure. Thanks.
I actually have a question here. So that I'm asking. Go ahead.
Okay. Sure. I'm Kim Hagan. I'm the Director of Member Services. The copays vary, but for our Medicaid population, our traditional Medicaid population, they're very nominal. And I'm looking over at my friend here. They are, 50 cents to $2.50 per. That's for pharmacy, right?
Office visits, ER visits.
Yeah.
No.
Okay. So here's my point. My brother takes x-rays. There was a young lady that went to church with us, and for several Sundays in a row, she had a crush on my brother. I don't understand why that would be. But nonetheless, every Sunday she would come up and she would talk about how she went and she saw my brother over the weekend. And I asked, well, what's happening? And she's, well, I thought I broke my back. And then the next week is she went back to the ER and she thought she broke her shoulder. And then she thought she broke her leg. And then she thought she broke something else. This went on for 5 or 6 weeks. And she was going to the ER so she could see my brother. And I'm assuming, I'm just assuming that there are people out there that are taking advantage of the system because they put no skin in the game. Is there anything that we could do to maybe put some safeguards around that? Because I can promise you that if somebody had to put $2 or $3, $4 or $5 every time they went there, there would be a different approach.
Yeah. Well, we are extremely limited by the responsibility that we can place on the Medicaid member, and we're restricted by federal laws and federal rules.
So we're kind of bound by federal laws. But is there anything that we could do at the state level? I mean, be creative. Is there something we could do to maybe help change the way?
Well, one thing I would point to is we work very hard with our health plans to try to coordinate care. And so if we see that we have a Medicaid member that is continually going to the ER or using the ER in an inappropriate manner, we try to interject and work with that member and work with the health plan. That's one thing that we certainly do.
Well, thank you for your time. I know it's late. Thank you, Chairman.
Thank you, Chairman, because you make a very valuable point. People don't value things they receive for free. And I'm a great believer in copays. They apply in many other spheres of life. Chairman Lafferty, you're recognized.
Thank you, Chairman. I was curious, the birth rates, the approximately 50% of the births in Tennessee covered by TennCare. I'm curious how much of that is single moms? What percent of that is struggling young families? That just seems like an incredibly high number to me. Can you give me some idea of the demographic breakup there?
I certainly don't know offhand what percentage would be single moms. We do know that it would be lower income families and individuals. We do know that, because in order to be eligible, they would have to fall into that category. But maybe we can look and see if we can gather any data. Do you have anything to add?
Hey, Victor Wu, Chief Medical Officer. Thanks for the question, Chairman Lafferty. I think the only thing I'll also just mention is, maybe piggybacking off the question around the eligibility categories for pregnant women on TennCare, we cover up to 195% of the federal poverty level, and then Cover Kids covers additionally to 250%. So there are oftentimes, while we cover up to 50% of all of our moms, many of these individuals may also have another type of insurance on top of that as well. So TennCare certainly provides supplemental coverage to make sure there's a robust comprehensive benefit. And some of these individuals may come on later in their pregnancy as a result of that. So we could work with you if there's any other specific demographic data you want to see, but just want to call out that while TennCare is covering up to 50%, many of these individuals may also have additional insurance on top of that as well.
Okay. Thank you, Chairman.
Thank you. Chairman Hill, you're recognized.
Thank you, Mr. Chairman. And I've got two things I want to go through quickly, but the first thing, and again, thank you for being here and thanks for your work, Commissioner and the whole team. But I kind of want to look at the pediatric dentistry side of things. There's roughly 9 million that's been set aside, but there's pediatric dentistry, home delivered meals, and enhanced respiratory care. It's all kind of lumped together. And I'm just trying to get some clarification. Is there an expectation, while it appears to be in a category, is there an expectation that it's going to be a certain amount for each one of those things? Could you just speak to that?
Yes. So the intent is to give equal percentage increases for those three categories. So it would be 5% for each.
Okay, thank you. And Mr. Chairman, if I may,
Sure.
There's been quite a discussion about the surplus, and I call it surplus, but you guys call it reserve. And I've heard numbers thrown about, is there an expectation that this year in this budget cycle that TennCare will be returning money into the general fund? And if so, how much, or not at all? What's the expectation?
Well, I think two things that I'll address there. So in terms of our reserve, so at the end of, June 30th of 24, we were at about 1.4 billion, but that actually is, it looks larger than it really is because all but 300 million of that is obligated, because that includes all of the unspent shared savings dollars that have been obligated. It includes the year 3 shared savings dollars that will be obligated in this budget cycle. And it also includes some non-recurring technology costs that we're going to use the reserve dollars to pay for over the next couple of years. So the way we look at it is we have 300 million unobligated, and that's a lot of money, but one way to think about that is when you have a budget as large as we do, $300 million with the federal match, it gets us about 18 days. If you take away the federal match, it's about 6 days. So it may not be as high as you think. The issue with the reversions that we've had, we've just been in a very unusual spot with the pandemic. We received enhanced federal matching dollars, and just transparently, we received more federal dollars than we needed to run the program. And so that's why we had those large reversions. We certainly don't, Chairman Sapicki mentioned the last two. We certainly don't expect something that large in the future because we're no longer getting those enhanced federal matching dollars.
Thank you. Thank you, Chairman.
Thank you. Representative Love, you're recognized.
Thank you, Mr. Chairman. And I would just like to applaud the work that I've seen TennCare do personally. I was a graduate student in '98 and had aged out from my parents' insurance, and my lung collapsed. But thankfully had signed up for TennCare. And if it had not been for that, I would not have been able to get the care that I got to repair my lungs at that time. And so I know oftentimes we talk about persons who are in a particular state in life, low income and in bad situations. But there are folks out there who, for no fault of their own, are in those situations. And it's good to have a program that we have that takes care of them and makes sure they can maintain their health. So thank you for that work.
Yeah, thank you.
Thank you. Chairman Parkinson, you're recognized.
Thank you for the chairmanship. Thank you for the chairmanship, Mr. Chairman.
Welcome.
I appreciate that. I received that. I receive it. Let me say thank you for your work. Did you? I know I'm sometimes a little bit tough on. That's because we have a great relationship that goes all the way back to education and other places. And so, but what's the total budget for TennCare? And I think I know I heard it in finance, but
Yeah,
just remind me if you will.
it's right now it's 18.6 billion.
18.6.
Now that includes state and federal.
Okay. Okay. And how much of that is federal?
Let's see, I
12.
have that. The federal amount is 12.4. Is that right? 12.4.
12.4. So, okay. So we're incredibly dependent on feds for this money to take care of our people. Okay. Let me ask you this. Can you tell me what are the differences in, let me see how I can ask this right. What are the differences in the available services for the individuals that have TennCare versus those that are on the safety net?
I'm certainly not as familiar with the safety net provisions and rules as compared to TennCare. I mean, I think our safety net providers that also are TennCare providers would be providing the same services, but I don't want to speak for the safety net because I don't know.
Okay. Anybody on your team know? Okay.
We'd have to defer to
Yeah.
Department of Mental Health and
All right.
Substance Abuse
I
Services.
think
yeah.
they took the signal from you. You said you didn't know. No, we
Yeah.
don't know either, right? No, I'm
Yeah.
just kidding you. I'm just kidding. And so what about the difference in access between, those available on TennCare and so actually being able to get to a doctor or get to the services? Can you tell me if there are differences there?
Well, there would be differences. I mean, I would say that because we are an insurance program, I think it's safe to say there's greater access through TennCare. But I also know we've done a great job in this state, and our sister agency has done a great job working with safety net providers. But I can't speak directly to the network of safety net providers.
Okay. You mentioned the strong economy, was part of, I guess, the reason for the decrease in the TennCare rolls. Now, I was told that the strong economy is the reason why, we got a different administration at the federal. I mean, the bad economy is the reason why we got a different administration at the federal level. So, is it a strong economy that caused the rolls to deplete or caused the reduction in the right? I'm on the bill, sir. Is it the economy that caused the difference in us? I think we were at normally 24, 25%. I think that's what Chairman said, and then we went to 20% of people enrolled.
Well, what I would say is I think Tennessee has a very strong economy, and when you compare Tennessee to the rest of the country, one thing to note is that we're actually our federal match is going down for the fourth consecutive year. And the reason our federal match is going down is because our personal income is going up, and that's measured relative to the rest of the country. Okay. So when we do better than the rest of the country, our federal match goes down. Okay. And that is what has happened now for the fourth consecutive year. So I can only speak for Tennessee. But relatively, our economy is doing pretty well.
Representative Parkinson, we are short on time. Would you yield to your fellow members?
Okay, I just have one more question, and if you want me to yield, I will yield, Mr.
Maybe
Chair.
we'll come back to you.
Okay. Thank you, sir.
Chair Lady Moody, you're recognized.
Good to have you and see you here. So this is a whole new world for me. So pardon me if my question sounds crazy, but my curiosity's been piqued with your pool of providers. I would imagine, I don't really know how they get involved, but I guess my question is, does there seem to be enough? Has there been a big fluctuation in the number of providers for these folks, or either way?
I would say for the last several years, we've had great consistency. We haven't had wide fluctuations. We have a really robust network of providers. It doesn't mean that we are without challenges, because certainly we are, just like every state Medicaid program in the country, and really we have challenges even outside of Medicaid. But I'm proud of our network. And like I said earlier, we have an exceptional provider group and provider network, and I think we're doing a pretty good job.
Thank you.
Thank you. Representative Hakeem, you're recognized.
Thank you, Mr. Chairman. Mr. Smith, Commissioner, I want to thank you also for the work that you and your team do. I think you're at times under a lot of pressure to do as much as you can with what you have available. And I think you all have done it very well. What I wanted to ask, there's a group of people that we normally refer to as the working poor, where a child is ill, one person in the family, husband or the wife, has to stay home with that child, losing money. Are they in a position to be a part of TennCare, to sort of lessen that burden on them?
They are, provided they meet the income thresholds and the income requirements. And so, the example that you just mentioned, that individual would be a parent, and so would fall under the parent or caretaker category. And so for that particular category, that individual would have to be at 100% poverty or below. Now, there are options available through the insurance exchange. So if you're above 100% of poverty, up to 400%, you can go on the exchange and you can get a subsidy. And if you're working poor, you may think about that kind of a lower level than 400% probably, then your subsidy is going to be higher. So there are options for some individuals, certainly outside of the Medicaid space.
Okay. I'm going to ask one other question, two questions in one, trying to be mindful of time, so forth. Is there a measurable degree of waste and fraud? And you had spoken earlier about, I think it was $1 billion in shared savings, where we got $1 billion. Was that $1 billion, or do we get half of that?
The billion those are the dollars that we have acquired from shared savings. So those are the dollars that we have available to us, and then we've reinvested those back into the program.
Okay.
Yeah.
All right.
Well, thank you. Representative Parkinson, you want to get your last question in?
Yeah, I was trying to get my last jab in, Mr. Chair.
Yeah,
Thank you, sir.
30
I'm just
seconds.
kidding. I'm just kidding. I'm just kidding. I'm just kidding. I just want to end with, I really do appreciate, I know this is a massive lift, and I really do, appreciate, everything that you all are doing. And it might seem like I'm tough, but I'm really a softie up here. So thank you, guys. Appreciate you.
Thank you.
Okay.
Thank you, Mr. Commissioner and team. Thank you for coming. It was a good discussion despite the late hour, but we appreciate what you do for our state and for the people that are on your program. Thank you.
Thank you very much, Mr. Chairman, members.
Without objection, we'll go back into session. Members, any other last minute thoughts? Seeing none, we stand adjourned.